Hello, this is Katrina, and today we'll be talking about hypothyroidism management. So we'll do a brief introduction, and then we'll do a pathophysiology review, talk a little bit about signs and symptoms, and then we'll talk about thyroid labs, meds, thyroid supplements, and then specifically nutrition related to Hashimoto's, and then we'll end with a case study. So hypothyroidism affects about 2 to 5% of women. The most common onset is between ages 30 and 60, and actually likely the most common time it presents is postpartum, so you're well primed to be in a position to screen for it if somebody's presenting with symptoms. So as far as a cause goes, in developed countries, the number one reason is Hashimoto's, or autoimmune thyroiditis. And then the number two reason would be iatrogenic. So maybe they've been taking medication like lithium long-term that have affected their thyroid, or maybe they had to have surgery and part of it was removed, and so now they need thyroid hormone replacement, that sort of thing. In developing countries, iodine deficiency is the number one reason. But we rarely would see that in the U.S. But something to consider, especially if you work with like an immigrant population that hasn't been in the States for very long. So for routine screening, currently there really aren't any recommendations. USPSTF says that they don't have good evidence to show for or against doing it routinely. Some have proposed, like for women who are 30 to 60, we should consider screening maybe every 5 years. Others have proposed maybe at age 50, if somebody presents with at least one symptom, to consider screening. Basically, jury's still out. So something to consider, though, would be if you work with a population that would be at an increased risk to consider screening. So older women are going to be at higher risk. Somebody with a strong family history might be worth screening at least once. Other autoimmune conditions, if you have Hashimoto's, you're also more likely to have celiac and other types of autoimmune conditions. So if you have somebody that's already got some autoimmune issues going on, it might be worth screening for Hashimoto's. There aren't any formal recommendations to screen in pregnancy, though it's been proposed a handful of times, and there are quite a few studies looking at the potential benefits of doing it. So autoimmune conditions, which is our number one reason in the U.S., autoimmune conditions are more likely to be at bay in pregnancy. So if somebody goes into pregnancy already with Hashimoto's, they'll probably be in a bit of remission during pregnancy. That said, pregnancy demands a lot of your thyroid, so some women end up being fine when they're not pregnant, but when they are pregnant, they might just need a little bit of support. Their thyroid might. So, they might just be on 25 micrograms of levothyroxine in pregnancy, and then when pregnancy's over, they don't really need it anymore. So I think if somebody's presenting super tired, it's hard because so many hypothyroidism symptoms can mimic pregnancy and vice versa. But if you have somebody that just seems extraordinarily exhausted or is having other symptoms, it might be worth screening them in pregnancy and just seeing if their thyroid could use a little extra support. And then lastly, postpartum, that autoimmune piece, postpartum is the most common time it can present. And for those where it does present postpartum, about a third of them resolve, a third get worse, a third stay about where they're at. But not uncommon after a year postpartum for it to have potentially resolved, but something to be watching closely for. So to provide a quick pathophysiology review, we have our hypothalamic pituitary thyroid axis. So our hypothalamus releases TRH, or thyrotropin releasing hormone, to our anterior pituitary, which then releases TSH, or thyroid stimulating hormone, to prompt our thyroid to make thyroid hormone, which is T3 and T4. So then we have our thyroid making those hormones. They're circulating through our body. They end up going back to both the anterior pituitary gland as well as the hypothalamus, saying, hey, my numbers are running low, and they, in response, will increase their numbers, and then it repeats itself. So if we have low levels of thyroid hormone, then that's going to prompt TSH. So mostly let's just look at TSH and T3 and T4 here. This is part of it, but not as crucial, especially once we start talking about labs. So TSH is sending a message, we need to make more thyroid hormone. So if our numbers are low, then TSH is going to increase. So it's sending a louder message, hey, we need more thyroid hormone. Versus if if our thyroid hormones are high, then we don't need to have a strong message. So then our TSH would go down, be like, hey, we need a little bit more. So we have a negative feedback loop here. Okay? So just to kind of reiterate that then, with hypothyroidism, we would have a high TSH. Our anterior pituitary gland is sending a loud message, hey, we need more thyroid hormone. And then we would see low levels of circulating free T4. Subclinical hypothyroidism would be a high TSH but a normal free T4. So basically implying we're heading towards hypothyroidism, but we're not full-blown yet. Oftentimes, the literature will distinguish between having a TSH that's between 4.5 and 10. So usually 4.5 is used as the cutoff. So between 4.5 and 10 for TSH would be like a low risk of it bumping up to being full-blown hypothyroidism soon, versus if it's over 10, then there's a high risk of it turning into hypothyroidism soon, even if our free T4 is normal. Even though there's not a lot of consensus about it though, if somebody's symptomatic and they have a TSH over 4.5, I'm going to still treat them. So some in the literature do, some in the literature don't. Again, we don't have consensus on that, but I find that it helps. So just in terms of your formal terminology or what diagnostic code you're using, it'd be subclinical hypothyroidism if their free T4 is normal, but they have an elevated TSH. And then for hyperthyroidism, we'd see a low TSH and a high free T4. So the hypo and hyper words are going to go to our free T4. So we have too much free T4, which is sending a message, hey, we really have a lot going on to the anterior pituitary gland. And in response, the anterior pituitary gland is going to send just a very quiet message, if anything, for a TSH. Now, 95% of the time, you're dealing with primary hypothyroidism, basically meaning that the origin is at the thyroid itself. So if the issue is at the level of the pituitary gland or the hypothalamus, you might be seeing thyroid issues, but almost always it's at the level of the thyroid itself, whether that's iodine deficiency, whether that's an autoimmune issue, it's primary hypothyroidism. Now, if it was secondary, such as like having like a tumor around the hypothalamus or the anterior pituitary gland, then you might see examples where labs are showing high for both or low for both TSH and free T4. So there are situations where you might see that, but almost always you're not going to see that. So I think it's easier to just kind of have these numbers in your head, or trends in your head. And if you're seeing both high or both low, then that can be something where you refer or do a little bit more research when you go to manage. So in order to make thyroid hormones, we basically need 4 ingredients. We need iodine, iron, selenium, and zinc. So I think that's important to recognize as we get into how we can help people manage it better when we think about nutrition, for example. So just a minute, I want to talk about T4 versus T3. So T4, there's a lot more of it than T3. It's about a 90 versus 10% ratio there. So you have a lot more T4 than you have of T3. And then all of T4 is made in the thyroid gland. Only 20% of T3 is actually made in the thyroid gland, so the thyroid gland is releasing both of them. But the rest of T3 comes from T4 converting into T3. So the 4 versus the 3 signals how many little iodine molecules are on it, on the hormone itself. And so in circulation in the body, T4 will ditch one of its iodines, which will turn it into T3, which is the more active form of thyroid hormone. So T3 is about 10 times more active than T4, so both can work on cells and cause a thyroid response, but T3 is far more active than T4. So think of it more as your precursor, and T3 is your active hormone. So this slide is just a brief review on signs and symptoms of hypothyroidism, so this should really be driving what you're asking for your review of systems if you're suspecting thyroid disease, and then it should also guide what you're going to be assessing. So thinning hair, hair loss, loss of eyebrow hair. An enlarged thyroid, you can find a goiter in hypothyroidism and hyperthyroidism, and more often than not you won't find anything. So just to keep that in mind. Slow heartbeat, poor appetite, weight gain, but poor appetite. Infertility or heavy menstruation. So both hyper and hypo can have period issues, but heaviness, crampiness is more of a hypothyroidism issue. And then sometimes carpal tunnel. And then the bottom here we see weight gain, poor memory. You hear about brain fog a lot as being a common experience for people having a hard time focusing in school, that kind of thing. Intolerance to cold, feelings of tiredness. Fatigue is the #1 symptom that people present with. And then, so we have that cold intolerance here. Constipation, dry, coarse skin, puffy face. And then another one that's not listed on here that I see both hypo and hyper sometimes is musculoskeletal achiness or pain. And then high cholesterol would be something else that you might come across that can be linked with hypothyroidism too. Okay, hyperthyroidism. So something to keep in mind, you're less likely to come across hyper than hypo, and I would say hypothyroidism you can absolutely be the primary caregiver for, or provider for. Hyperthyroidism, I personally would be a lot more likely to refer them out to an endocrinologist. However, you might come across symptoms of hyperthyroidism if you're working on trying to balance your hormone replacement dose, like with levothyroxine. If you give too high of a dose, then they might be having symptoms of hyperthyroidism, and so then we're backing off of our dose. So you might see patients present with one or the other, especially if they're in the process of already being managed. Also with Hashimoto's autoimmune thyroiditis, I'll often see patients kind of swing back and forth from hypo to hyperthyroidism symptoms. So in terms of their labs, they're hypothyroid, but if they've had antibodies that have been attacking their thyroid, occasionally their thyroid might mount a response and try to kind of overcome it and overcompensate. So to have them kind of fluctuate between hypothyroidism symptoms when the antibodies are winning and then hyperthyroidism symptoms when their body's kind of mounting that response against it, makes it not uncommon to see like a combination of anxiety as well as fatigue and kind of that combination of symptoms. I don't know if depression was on the last slide, but that would be another one I would associate more with hypothyroidism versus hyper. I would be more likely to see anxiety. So I think they could have added a psych category to this image. Okay, so hyperthyroidism, that classic bulging eyes, potentially an enlarged thyroid, abnormal heart rhythms, so more likely to have palpitations, or they might feel like their heart's beating out of their chest. Increased appetite, especially alongside weight loss, loss of libido, amenorrhea, so I see them being more likely to have irregular periods, or really light periods, or no periods for hyperthyroidism. And infertility can be with both. And then we see here in the bottom corner, irritability, hyperactivity, high blood sugar, intolerance to heat, so that cold versus heat between the two of them, low cholesterol, might see hand tremors, kind of, again, that like anxious persona, nausea, vomiting, diarrhea, same thing, if you want to think about kind of a gestalt image. Potentially an enlarged liver, increased perspiration, and then fine brittle hair or hair loss. So you might see hair loss with both of them. Okay, so let's take a look at thyroid labs. I've got our little diagnosis reminder up in the corner here for distinguishing between hypothyroidism, subclinical hypothyroidism, and hyperthyroidism. And then over here, TSH is absolutely going to be our most sensitive test, and especially once you already have somebody officially diagnosed and you're just managing their medications, all you really need to be checking is a TSH with a reflex to free T4. It's not like you need a full panel every time. This is really the primary lab that you're drawing and basing your management decisions off of. So most labs will put 0.4 to about 4.5. I've seen it as low as 4 and as high as 5 in the literature, but that's generally what we're shooting for. And then in pregnancy, it's a tighter range. So the reference range for your lab, like if you put in that their diagnosis is pregnancy, they'll give you a range for each trimester for what would be considered normal. They're all going to be less than 3. If I'm managing somebody who has hypothyroidism, I find that just about everybody does better if their TSH is less than 3. So I'd like to see it in the 1s or 2s. And if I have somebody that really isn't meeting full criteria for having hypothyroidism or even subclinical hypothyroidism, but they have a lot of symptoms, if they're over 3, I may still consider treating them, especially if it's like a combination of infertility and irregular periods. I've seen, someone come from a 5 down to like a 2.5, and then they start having more regular cycles again. So even if they're not fully meeting criteria, I would think about maybe lowering what your threshold is for treating for TSH. So TSH is going to be best both for screening as well as for ongoing management. But typically, if you're drawing a TSH, you're going to reflex it to at least a free T4. So for both T3 as well as T4, they're typically bound to proteins in the blood or albumin in the blood, and it's only what's free that's actually usable. So if you draw a free as well as a total, that can give you a sense like how much of this is actually active. So that's your basic reference range you'll probably see in clinic for a free T4. And then again, drawing the total can give you a little bit more perspective of what you're doing there. I typically will only draw a full panel if I've just diagnosed somebody for the first time, and I probably just screened with a TSH with a reflex. But if it comes back that they have hypothyroidism, then I'd want the full panel to just assess where they're at. And then otherwise, every few years I might check in, like somebody who's been well managed for a while. Or if we're having a hard time, like maybe our labs are looking okay when I'm doing a TSH and a free T4 with the medication we're on, but they're just still not feeling great. If they're still symptomatic, then I might draw a full panel to see if that'll give me more insight. So that's our free T4 and our total T4. And then just as a reminder, so this is what our T4 looks like. And then it loses 1 iodine and becomes T3. So T3s are active form. So for free T3, we want that to look good. Usually, like that's not going to be any part of your diagnosis, but like if I have somebody whose TSH and free T4 looks great, but she's still just feeling so wiped every day, and it comes back that her free T3 is low, then I might consider a different management approach for medications. And then anytime I draw a free T3, I also like to see a reverse T3, because this will be able to attach to basically any cell in her body and do its thing. This can't. And so if we have what looks to be somewhat of a normal, or maybe it's a little low T3, but a high reverse T3, it's like when her T4 is ditching an iodine, she's sometimes ditching the wrong one, and then it's not active. So sometimes that will trick us into thinking that we're fine when we're not fine because this is so high. So that would be something to look at as well. Okay, so then that gets us to antibodies. I basically want these to be 0. If they're 1 or 2, I'm not going to think much of it. Generally 30 is considered the cutoff for calling it Hashimoto's for TPO antibodies. I've seen some sources quote as high as 100, but I would use 30 or even less. If somebody has Hashimoto's and I can get her antibodies down below 30, then I consider her in remission. I find that most Western medicine sources don't put a lot of stock into checking antibodies, so I've had quite a few women come into clinic that maybe have just moved to the area, and I'm going to be taking on their thyroid management ongoing, and they've actually had hypothyroidism for years but never had their antibodies checked. The level of her antibodies is not in any way going to affect what I'm going to prescribe for medication for thyroid hormone replacement. However, if her antibodies are high, then it's about a 5% loss in thyroid function every year. So progressively, she's going to continue to need like slowly, but an increased thyroid hormone replacement dose. So if we can get her antibodies under control, then at the very least, hopefully we won't need to continue to increase her dose over time. And then in some women, I've seen it be able to go down, or even for them to be able to go off of their medication altogether. I don't promise that, but I've seen it. And that's going to be primarily through supplements and diet. So we'll approach that coming up here. But basically, for the thyroid itself, for the thyroid gland itself, I explained that it's like they have a barrel full of water, and then there's holes in the barrel, so the water's leaking out. And so our main solution to that is to pour more water in the top. So that's giving thyroid hormone replacement, such as levothyroxine, for example. It doesn't make her body more dependent on it. It's replacing what's missing so that her body can function more normally again. And then if we address antibodies, that's our attempt at plugging up the holes so that we don't need to be pouring so much in at the top. So when it comes to management, though, for your levothyroxine dose, you're just going off of TSH, alongside a free T4, but mostly just TSH. Okay, other labs you might consider drawing in somebody with a thyroid issue. Vitamin D has been low vitamin D levels have been associated with Hashimoto's, so I think it's worth getting a baseline and shooting for about her being about 60 to 80. Usually labs will say 30 is normal, but you're going to want it higher for somebody with Hashimoto's. I would say higher for most people, but maybe 40 to 60 I feel good with for everybody else. 60 to 80 for somebody with Hashimoto's. As CBC, you might consider drawing if you're not sure if she has a thyroid issue and you're trying to rule out maybe other sources of fatigue, so that could get anemia. And then a cholesterol panel. If you know you have somebody with Hashimoto's, it'd be worth checking in more often that their cholesterol is fine, because it will be more likely to be high. So medication management. How often are we drawing these labs? So you've just diagnosed her with Hashimoto's. You're going to start her on a medication, have her come back in 4 to 6 weeks, and you're going to check a TSH with a reflex to free T4. So if this is high, you'll get both. If it's normal, then we don't need both. We're fine with just a TSH. So every 4 to 6 weeks, you'll have her come back in. You'll tweak her dose. You'll send her out again for another 4 to 6 weeks until her dose seems like we hit the right spot. Her TSH looks great. And then once you're in a good place with it, ongoing, you can just check in annually. Grab a TSH with a reflex. If it still looks good, prescribe it out for another year. And probably more commonly what you're seeing is somebody coming in for an annual, establishing care with you, and you're going to take on her thyroid management, and she's already got her dose that's in a good place, and you're just doing maintenance. And then antibodies, if we're going to be doing lifestyle modifications to see if we can lower them, the earliest that you can see if one of those lifestyle modifications is making a difference is 3 months. So they say they're going to make a change. We're going to wait 3 months before we check antibodies again. All right, on to medication. So almost always, you're just going to be giving her a T4. So levothyroxine or Synthroid is synthetic T4, and then that really, of all of our thyroid medications, it's very highly calibrated. So if a mom isn't coming in or a woman isn't coming in with kind of a strong opinion about it, that's typically where I'll start. As in, if it says I'm giving her 75 micrograms, chances are it's going to be very close to 75 micrograms. Versus if we use Armour Thyroid or Nature Thyroid, which are both natural thyroid hormone, it's pig hormone, or pig T4, it's more likely to be just a little bit off. And so if you're having a hard time getting somebody's dose just right, I'd rather work with levothyroxine. That said, sometimes people don't respond super well to levothyroxine. So, you know, if we've been on it for a while and her TSH looks great, but she's just not feeling great, and all her labs are looking fine, like we've done a full panel and it's not like we have a high reverse T3, there's not something else going on, then sometimes switching to more of a natural form, such as using the pig T4, will be what she needs. And I've seen that work great for people too. Or if somebody comes in and they're just already having a hard time swallowing the idea of taking a pill every day, no pun intended, then sometimes the idea of using a natural form versus a synthetic form, they're willing to try it. Worth noting that both of them also have a little bit of T3 in them too. So, be watching for people coming back with having hyperthyroid symptoms, because if you're giving T3, you're more likely, because it is so active, to have swung the other direction and start having hyperthyroid symptoms. So it's mostly T4 with a little bit of T3 thrown in. And if you're switching from one to the other, I just pasted this in so you could see. If you just Google it, there's conversion charts like this that let you know, if she's on 75 micrograms of Synthroid and we're going to switch to Nature-Throid, that would be the equivalent of 3/4 grains or 48.75 micrograms. Where's that? Milligrams. So then you'd know how much to prescribe to give her the equivalent. Sometimes you want to knock it down just a little bit lower, just because having the T3, sometimes you don't need an exact conversion. It'd be okay to go just a little bit under, and then symptom-wise, it hits you about the same spot. Okay. And then lastly, sometimes you might consider giving T3. So I would consider giving T3 if a TSH was normal, a T4 was normal, but your T3 is low and she's still symptomatic. I'd probably give both, like Synthroid and Cytomel, and I'd just start really low on T3 and just see if that could get us to where she felt like her symptoms were managed well. Really mixed in the literature. Some feel strongly like don't even go here. Some write about how it's been the perfect solution for so many of their patients. There's no formal guidelines around it. I'd say don't be scared of it, but don't be giving it to everybody. And actually, same goes with if their TSH and T4 have looked fine for a while, but and their T3 is fine too, but they're just still pretty symptomatic. I may still consider just giving a little bit of Cytomel in addition to Synthroid. I know compounding pharmacies sometimes they'll combine them and give you a T4, T3 combo pill, so she just has to take one pill. So that would be an option too. And that's something I personally haven't really explored, just because I love knowing that it's really highly calibrated, and I feel like I lose a little bit of that if I'm using a compounding pharmacy when you're trying to get just the right TSH. Okay, so 90+% of the time, I'm guessing you're just working with levothyroxine. So if she has subclinical hypothyroidism, I would start her out at just 25 to 50 micrograms and then recheck in 4 to 6 weeks, and then you can increase by about 25 micrograms each time. If she has full-blown hypothyroidism, where her TSH is elevated and her free T4 is low, know that the average dose tends to be about 100 to 150 micrograms. So if you want to start higher, you can, if you're thinking you're going to need to end up being at a higher dose. So you could start at like 75 micrograms and then again slowly going up from there, about 25 micrograms with each check. So again, waiting 4 to 6 weeks to check her TSH and then increasing as needed until her TSH looks good and her symptoms are well managed. So that's the general approach. And then know that if you keep kind of popping between 2 doses and you're having a hard time getting your TSH right where you want it, you could, not ideal, but you could do, say 75 micrograms 4 days a week and then 100 micrograms 3 days a week. So she could go every other day too. And then just a note of caution, if you're working with an older woman, or the elderly, then it would be worth starting out even lower and then going up slower, so we don't do too much at once. Okay, so quick note on thyroid supplements. So some of this is going to apply to everybody. Some of this is specific for your women who are have Hashimoto's and we're trying to get it down. And granted, that is the #1 cause in the U.S., so it probably will be a lot of the women in your care who have Hashimoto's. So we already mentioned that there's a link between low vitamin D and Hashimoto's. So check her labs and see if we can't get that up. Probably we're talking 5,000 IUs a day, something like that. Probiotics, gut health is really important for autoimmune conditions. So being on a good probiotic is a great way to do that. Minerals, a lot of these, again, this is just going back to the ingredients needed to make thyroid hormone. So we want to just make sure that this is in place well. And I would say heavier emphasis on selenium and zinc. And then there's actually been some research showing that iodine supplementation, specifically for women in Hashimoto's, makes it do a little bit worse. So I want it to be adequate, but I'm not trying to over-supplement on iodine. Again, that'd be different if your patient population is prone to an iodine deficiency, or again, maybe somebody who recently moved to the States from a developing country, for example. And a lot of that might just be able to be captured in a multivitamin, so it's not like we need to be taking a million pills. Plantar pine sterols is something I consider doing with women who are wanting to really focus on lowering their antibodies. There's been a handful of research, not a ton, but basically any autoimmune condition, RA, Hashimoto's, that it can help lower antibodies. So that would be something to consider doing. Like Thorne is one brand that comes to mind that has a good product for that. And they could just do like 2 capsules a day. And then I just wanted to highlight a few herbs. So Goggle improves T4 to T3 conversion. So I think it's just nice to make sure that that's in place well for anybody with an autoimmune condition, but especially if you've got somebody who has low T3, that they're able to make that conversion well. Adaptogens. Adaptogens are basically like a category of herb that are really good at like lowering cortisol, balancing thyroid hormones, helping people cope with stress, balancing both anxiety and depression. Great for fatigue, great for both adrenal and thyroid support. So ashwagandha and eleuthero are 2 of my favorite adaptogens, and they would be great for Hashimoto's, or really anybody dealing with fatigue. Adaptogens are great for that. And worth noting that if your thyroid's been tanked for a while, she's going to be dipping into her adrenal glands. So having adrenal issues is a common, more or less a side effect of having a thyroid issue. So it's good to have some support for both of those. Let's see, coleus is good for cortisol and metabolic support in general. So that can be helpful. And then turmeric is so good both dietarily as well as in supplement form for any kind of inflammatory condition. So all your autoimmunes, it would be great. And then I just gave you an example here. I have nothing to disclose. I'm not in any way associated with Pure Encapsulations, but I really like their thyroid support complex, and there's a number of different brands that would put out some form of a thyroid supplement. So you can see that this captures a good amount of zinc, a good amount of selenium. It has just a drop in the bucket of vitamin D, so I'd like to have her be on this as well as more vitamin D. And then it has a few of those different herbs that I talked about as well. I wouldn't do this in pregnancy. I'm not a fan of ashwagandha in pregnancy, but but for women who aren't pregnant, this would be a great option. Okay, let's talk a little bit about nutrition and thyroids. So for Hashimoto's, we have an autoimmune condition, and so gut health really is going to be key here. If we have a permeable gut, then it's easier for like bigger substances like proteins to not be fully broken down when they're absorbed in the bloodstream, and that can trigger an autoimmune response and more antibodies to be formed. And probably one of the biggest triggers for having a permeable gut is gluten. So you can even think about it as both gluten in the bloodstream as well as anything else that can get in the bloodstream, because gluten has made that wall of the intestines more permeable, will lead to more antibodies being formed to attack those substances, but then those same antibodies can attack her thyroid. So if we can bring down gluten and heal her gut better, then those antibodies will go down, and then those antibodies aren't there to be attacking her thyroid. So Hashimoto's, I'm not somebody who recommends a gluten-free diet for everybody who walks in the door. Celiacs and Hashimoto's are the 2 times that I always do. And unless she's postpartum and maybe is able to kind of recover and work her way out of it in that first year, I'll still recommend gluten-free for that year. But everybody else, there's a decent chance they're going to need to be gluten-free long-term. So just kind of setting that expectation. Sometimes it's about a 50-50. Sometimes people who are sensitive to gluten are also sensitive to dairy. And she might not have any gut symptoms or anything that even tells her, yes, I'm eating the right thing, or no, I'm eating the wrong thing. But there's like a cross reaction where if you're sensitive to gluten, about half those same people are also going to be sensitive to dairy in terms of their gut health and in terms of how we see their antibodies respond. And then, so I kind of gauge it based on how overwhelmed they look. But if they're game for being gluten-free, dairy-free, soy-free for 3 months, let's check your antibodies again, see how we're doing, and go from there. It might take us a year to get them down. I'm just throwing a time frame out there, maybe even 2. But I think it's easier to do everything, like take out everything, gluten, dairy, and soy, and then once we get our antibodies less than 30 and she's starting to feel good again, then slowly reintroduce soy, reintroduce dairy, and see if we can basically be fine with just gluten. But if she's really overwhelmed, then we'll just do gluten. Or nothing, I suppose, too. And then I think it's a matter of just talking about, if you're not pregnant, the main risks would be that we'd progressively need a higher levothyroxine dose, and then just that it can affect your cholesterol. If we are talking about pregnancy, though, I'll leave that to your antepartum course. But basically, even with like a TSH that's well controlled, having high antibodies in pregnancy can increase her risk for both first and second trimester loss, preeclampsia, among other things. So sometimes that's her motivation to get her antibodies in a good place, is because she's hoping to plan another pregnancy soon. And not so high to say, like, don't get pregnant, but just to be aware of increased risks and to be aware of what can help improve her situation. So gut health, gluten-free is key there. Probiotic foods, sauerkraut, milk kefir, kombucha, everything like that, kimchi, Greek yogurt. Low sugar in general is really good for gut health. Bone broth's really good for gut health. If she's game for doing a Whole30, I think that's a nice kickoff. It's a little bit more than she needs to do for this, but it really does address everything she needs to be addressing well. So sometimes even that can be helpful for finding recipes. Whole30 would be great. Basically anything paleo is fine. There's Hashimoto's cookbooks online. Yeah. And then selenium and zinc, I would say if she's not wanting to do a selenium supplement, it'd be like 3 Brazil nuts a day and she's good. But I have a list here of selenium-rich foods, so you can talk her through that too and just make sure she's getting those kinds of food in her diet, making sure she's getting adequate zinc as well. I've got your nice little pictorial guide there. And then adequate iodine, again, not going crazy with iodine, but just making sure we're not clearly lacking it. And then this is a little bit of a mixed bag, but goitrogens are basically foods that can potentially interfere with what the thyroid needs to function well. And the main culprit here is cruciferous veggies, so broccoli, kale, Brussels sprouts, cabbage. These are foods that are really good for you. So I don't tend to tell people to avoid them, but just wanted you to be aware that that debate's out there and that we might see more research on that in the coming years. So let's do a case study. We have a 32-year-old patient who presents 6 months postpartum. In the last 2 to 3 months, she's gained 50 pounds and is constantly exhausted. Her labs come back as a TSH of 12. I've got your reference ranges there. A free T4 of 0.6. and TPO antibodies of 120. So what would your diagnosis be? So she has Hashimoto's. We know that because of her antibodies. And I'm actually going to just rewind real quick here. If you have antibodies that are elevated but normal TSH and free T4, I think of this as only a matter of time. And she doesn't need thyroid hormone replacement, but if you've got elevated antibodies, I would initiate everything else to see if we can lower them so that we don't eventually develop needing levothyroxine. So I just wanted to put that out there. So we know she has Hashimoto's, or autoimmune thyroiditis, because of the antibodies. And then our other diagnosis is just going to be hypothyroidism. Both her TSH is too high and our free T4 is too low. Would you start her on medication? If so, think about what you'd start her on. How about any supplements? If you are going to start her on a medication, also think about what your dose would be. Any dietary changes? And when would you want to see her again and for what? So you can pause it here and think about what you'd want to do before you move on. Okay, so let's just say for the sake of this case study that you decided to start her on levothyroxine and you put her on 75 micrograms a day. You just went for it and said, I think that's where we're going to end up needing. She's super exhausted. We've gained so much weight. Let's just try to get her to the right dose quick, rather than, say, starting at 25 micrograms. She also started supplementing with a probiotic, vitamin D, pine sterols, and that thyroid support complex that we talked about to help with getting in some of those other minerals and some other herbs that might help. So she started eating strictly gluten-free and is mindful of your other general nutrition suggestions as well. Okay, so she comes back to the clinic 6 weeks later, and her TSH is now 0.4. Her free T4 is 2.7, and she states she's feeling a bit less exhausted, but has been feeling anxious and has trouble falling asleep at night. Sometimes she feels like her heart's beating out of her chest. Her weight is unchanged. So pause for a sec and think about what might be going on, and is there something you'd want to do with her medication? So you can see that technically her TSH is fine. It's on the lower end, but normal. Her free T4 is a bit elevated. But then we also see that she's symptomatic. So sometimes we're treating straight labs, and sometimes we're treating a little bit of her symptoms too. So it looks to me like we probably started her just a little bit too high, particularly given that she's having symptoms. So why don't we try tweaking her medication? So we lower her dose from 75 to 50, recognizing that she started her journey with us having hypothyroid symptoms, and then we gave her thyroid hormone, and then she started having hyperthyroid symptoms. So we're lowering our thyroid dose, and then we tell her to come back in 4 to 6 weeks. We'll see how that goes. She returns 5 weeks later, and her TSH is now 1.3. That's normal. Free T4 is 2. That's normal. And she states she feels overall better. Her exhaustion and anxiety are both mostly improved, and her weight is still unchanged. So go ahead and pause and think about kind of what your assessment or overall gestalt of her is right now and what you'd want to do for follow-up. Okay, so I would say overall this looks good. It's hard to get it just right, and we're not going to do big medication swings to go after just a little bit of anxiety or just a little bit of exhaustion. It'd be too hard to get our dose just right if we were going to do that. So given her labs are good and overall her symptoms are better, let's just stick with 50. Her weight is still unchanged. It's hard to get everything just right when you're managing a thyroid. And it's hard to lose weight. So I would treat that, if that's a priority for her right now, I would treat that in terms of just general nutrition and exercise and weight loss counseling. So overall, feeling like her thyroid's decently well managed. Now she is doing things to try to lower her antibodies. So for follow-up, I do want to check and see where her antibodies are at 3 months from wherever she first started with that. And then I don't want to wait a whole year to check back in on her dose. So we'll probably go ahead and check a TSH again when we do those antibodies. And then maybe if in 3 months, if we're doing the antibodies again, like we start doing those every 3 months, then I'd probably go ahead and check her TSH again. At that point, and if it still looks good, then might wait 6 months before checking in on her TSH. So something loosely like that. Also recognizing she's postpartum, so there's a chance she might resolve. And so I think going over her symptoms really well for both hypo and as well as hyper, if she's starting to experience either of those, that would be worth us checking back in and making sure her dose is still good. And that's everything I've got for you guys.